Welcome to The Virtual Shift, a show looking at the seismic changes happening in healthcare with virtual care at the epicenter. Join me and my guests as we look at key cultural and policy shifts impacting how providers, payers, and patients connect, as well as how care is being reimagined both for today and the future. Hello, and thanks for tuning in today. I'm your host, Tom Foley. You can learn more about this show by visiting the program on healthcarenowradio.com, and be sure to follow me on LinkedIn, Twitter at FoleyTom, and the hashtag The Virtual Shift. We have today with us Michael Grace. He is the CEO of MAG Global Holdings, Inc. Michael, welcome to the program.
Thank you for having me.
Awesome. So, Michael, as you know, we have been talking about many things. If those listeners who were listening to last week's program, we were talking about a Pulse Institute article that you were featured in. Top healthcare executive Michael Grace speaks out on health crisis and poverty in the Black community. So this is a part 2 segment of the discussion. So I hear you on leadership. I hear you on the community, the lack of presence. You know, I can remember speaking at the Qualcomm conference, healthcare conference a couple years ago. And I said, you know, it seems like the communities are fighting over who gets the attention of the patient as opposed to paying attention to the patient's needs. And because there is a difference there. But the point there being is there just needs to be a different way. And I'm not calling for healthcare reform. I'm calling on the need to pick up the communities in a different way. Because we talk about revitalization programs, we talk about shovel-ready programs, if you will, and they're all good, right? But those programs, it only takes a couple of years to build a road, and then the road is done, right? So it's really about long-term sustainability of a community. And yes, there are a number of people that grew up in poor homes. I was one of them, frankly, and I know you were another. And, you know, we get out, if you will. And because we found a way, we found people that saw something in us that we didn't see in ourselves. But the idea of doing healthcare reform on its own, in my view, isn't enough because it doesn't address the economics of the home, right? We talk about the healthcare and the home being a setting of care, but if the home is not stable, then the delivery of care cannot be stable in the home. The point there being is, we talked offline before about having economic stimulus in the communities of greater need. And because that economic stimulus, in my view, creates jobs. And what is the greatest demand in healthcare today? Nurses. We should be investing in our young people and not having the debt of a college tuition in front of them, but investing in young people to get into healthcare. There's such a great need for a number of different types of resources, and to me, it seems like there's a coupling of economic reform and jobs development and healthcare reform, for that matter. So, any thoughts on that?
You know, what I would say is healthcare reform to me is just more documents to read with no action. I think that when you're in the communities and you're teaching, instead of everybody scrambling. You know how we scrambled for COVID vaccines? Every time I travel to California lately, you have to show your vaccine card on the sidewalk before you even walk into the restaurant. We don't educate in inner cities. One thing, one of my heroes, Martin Luther King Jr., said, when you make it to the top of the stairs, you go down and you pull others up. Those that have no foundation on which to stand. Those that don't have a foundation on which to stand are the least of thee. They're often forgotten. Those are the people that show up in the emergency room. They get to the point where they're segmented because their mindset shifts and change. They don't take care of themselves. Nobody really focuses on them. You mentioned earlier hospitals fighting for the same patient. We know who those patients are. We have algorithms now, demographics, where we can say this zip code has this demographic, this population. These are the top 5 diagnoses or disease states. And we could really hone in on that and put a heat map over it. These individuals believe that, why do I need to take care of myself? That's your job. You're the doctor. And as you go up those stairs, each mindset shifts till you get to the point where you get to those that know that it's their responsibility and they should take care of their health. But we don't reach back and try to educate. And then our emergency rooms are so packed because they use that as their primary care physician. Those hospitals go on divert, especially on weekends, and you may have a serious injury and you got to go to a hospital 5-10 miles from where you would normally be treated because of all of these different determining factors. If we can, whenever there is a specific disease or a chronic illness that could occur, we rally around that. We push vaccinations. And if you didn't get it, there were options. There were exemptions, but at least you responded. You knew about it. When we
Yeah.
thought that we all were going to die and we were going to have this big outbreak of Ebola, we spent so much money in preparing for that only to have a few. We're always in this country in a reactive state instead of proactive. Social determinants of health, disparities are proactive and need to be that way. And
Yeah.
we just proved we can do it. US, we can do anything we focus on.
That's right.
You know, there
That's
and
right.
one of the things when you see all these drugstores that populate and pop up, when you start seeing it, you're like, oh man, what's going on? We realize there's no profit in the cure. The profit is in the treatment and just, here, this will make you feel
keep
better.
keep giving them the diabetes medicine,
Yeah,
because there's no insight or no level of awareness that you could put diabetes in remission,
yeah.
because you could diet and exercise, specifically type 2. I want to again pull in from Jesse Jackson's comments when you talk about America can do anything. Jesse Jackson says in 1984, our flag is red, white, and blue, but our nation is a rainbow: red, yellow, brown, black, and white. And we're all precious in God's sight. He goes on to say, America is not like a blanket, one piece of unbroken cloth, the same color, the same texture, the same size. America is more like a quilt: many patches, many pieces, many colors, many sizes, all woven and held together by a common thread: the white, the Hispanic, the black, the Arab, the Jew, the woman, the Native American, and the small farmer, the businessman, the environmentalist, the peace activist, the young, the old, the lesbian, and the gay, and the disabled make up the American quilt. We all have to be on the same ship, if you will. And to my view, there has to be enough already position of this is got to change. And like I said in the previous episode, individuals might have risen, but we have to do a better job of raising the community so that there is, and I think to some degree, when specific demographics go to a doctor's office, there might be, to your point, some level of racism, I might say, in the context of it's an episodic moment. Care delivery is a 24/7 activity. I need someone in my home to coach me, right? I just told you 2 weeks ago you had diabetes, but you're still eating that, you're still drinking soda, and you're still eating that jelly donut, hypothetically. I need someone on a 24/7 basis, if you will, to be my health coach, guide you out, as opposed to saying that you got diabetes and I'll see you in 3 months, right? And just so you know, my father had diabetes, and he then never listened to a damn thing his doctor said, frankly. But he then had dialysis at home, right? And then he had a leg amputated, another leg amputated, an arm amputated, and a couple fingers on the other hand amputated. So diabetes will hurt at the end of your life. It might not hurt now, but it drives a lot of pain in the context of the individual, the family, the community, and an unnecessary burden on the financial side of the equation when it all could have been prevented by greater awareness and better engagement and more empowerment of the consumer. Thoughts on that?
Yeah, my parents had diabetes as well, and my mother and dad never listened. I don't think any of our parents listened to what. Well, he just said it was a little, and I'm gonna eat this honey bun with this slice of cheese, but I'm drinking a diet soda. It, but
My
that
mother
was
was Italian, and I always said that my father's contribution to his diet was drinking a diet soda.
yeah. So again, it goes back to what I said earlier: education. And when you mention the racism along the lines of healthcare, a lot of that is education. Some of it is unintentional. Some people just don't know. Then some people get mad at minorities and African Americans because every time I see you, you're in our emergency department. So we just gonna make you wait. Oh, you have Medicaid? No, we're gonna get all these blues and Uniteds and Aetnas first, because one of the things we look at in healthcare is payer mix. And we can be nonprofit, but you still got to have a contribution margin to exist. When you look at the shape of Medicare and Medicaid, and you look at the demographics of Medicaid, it's over 20 some percent that are minority communities that are on Medicaid. And there's only so much you can get on Medicaid. And also, we have those that come into the emergency room that have no insurance. You're going to sit for quite a while. And who are they? When you look at the faces of those people, and do they get the same level of care I do with my Blue Cross card? Depends on the doctor, depends on the nurse. We deal with metrics a lot in healthcare. And one of those metrics is, Tom, how long does that doctor spend with you? Because you got a certain amount of patients you got to get to in this hour. And
Mm-hmm.
today you got to have also include telephone visits. You got to include email because doctors, now can get chats and emails from patients. Plus, you got to do telemedicine time. So we're going to give you about 7 to 8 minutes in that exam room. And we might send a mid-level in first. And we might come in for those 8 minutes and just have some conversation for about 3 minutes, do a quick exam for about 4 minutes, and then say, I'm going to write you this, and I'm going to have a follow-up, and Jane will write up our next meeting. I want to see you back in 6 weeks. That's it. You may come back, you may not. And is anyone asking you, do you have transportation to get here? Will you need a ride? Is
And is
anyone
anyone
really in?
even checking that you're coming
Yeah,
back?
is
Right.
anyone
My waiting
even?
room's already full with or without you.
Yeah,
Right.
right, right. That is part of the breakdown. Oh, and you're on Medicaid? Oh no, we not gonna call you. And just look at all of these insurance managed care companies whose job, Tom, is to say no. Well, we couldn't get authorization for. We couldn't get authorization. We know you dying, but we couldn't get authorization. I mean, really? Is that what, when we talk about healthcare reform, when we talk about delivery of care, care transformation, is that it? Is that what
What
we become?
what happened to do no
Authorization?
harm? Yeah.
Authorization? I need authorization to live? Oh, my medication is so expensive. Let's see, do I buy that or do I feed my kids? Is that healthcare reform? How many presidents now? How many healthcare
Well,
reforms have been written? What do they mean to the everyday person? To changing and shifting the paradigm.
exactly. Two things happen when we have healthcare reform. Doesn't matter what president. Consumers pay more and doctors get paid less. Those are the two things that happen. Now, with Obamacare, you might have had greater access, which is true. However, ask those folks that had greater access whether or not they could afford the copays once they got engaged, right? And so it took a step, but it was only the first step. There's many steps up to the chapel, so we got to change. And this we have, I think, about 10 minutes left. Mike, and it's been a great opportunity and privilege to speak to you in the last episode and this episode. So let's focus on what do we think. Let's let you know we are Congress, you and me. What do we think needs to happen? Two things, because the third thing always gets dropped anyway. If I were writing legislation to reform healthcare, what would you like to see in that bill?
So what I would like to see is what you mentioned in Reverend Jackson, who's, by the way, is a very good friend of mine's 1984 quilt speech.
One of the
The
greatest
different
speeches I've ever heard. I remember listening to it live on television. I still remember it today.
and how diverse this country is. Why can't it just be one healthcare for all? Why can't there be, since you and I are in Congress and we're writing this legislation, why can't we just have simple legislations that, as we often hear, for the people, by the people? I have not once been to one of my congressional districts, wherever I live, meetings, and heard a candidate say anything about what they're going to do to change how healthcare is presented. It's just a lot of talk. It's like we say, oh, it's bar talk, which means they've had a few and you can't believe anything they say. And they are not really. So you go to this, where do they go first? They go to a senior citizen building because they know those folks vote, but they haven't done anything to help them with healthcare. Because why do I need to have Medicare in four parts? A, B, C, and a D, and a supplemental. Really? I just can't have insurance that covers everything? Why do we make it so complicated, Mr. Congressman? Why aren't
So
you writing legislation around that?
do you think that I often hear from Congress and the idea of changing legislation, it has to be a net zero impact to budgets and things of that nature. To me, that is a roadblock, not a solution, because at the end of the day, if a tragedy comes up. And, to your point earlier, we respond well to tragedies, but we're not proactive and we're not leaders. So the point there being is we know the tragedy here is healthcare,
And
and
we get excuses.
we get
And to,
excuses.
and
Exactly.
excuses are tools of the incompetent who build monuments of nothingness, and those who specialize in them seldom make good at anything.
Exactly. And we have two parties that are really just at battle with each other, and therefore nothing's going to get done. So my question is, I don't if we did this healthcare reform, you know we ultimately seemingly need to put more money into it, because if because the point is that I still am in this community and I can't afford the copays. It's got to be a system where if you are in a certain economic threshold, there has got to be some cushion, if you will, that says, yeah, this person has diabetes, they're obese, and they need help. And it's not just coming in every 6 weeks. That's BS. Right? I need to put them on a program, and I need to engage them daily, collecting their vitals, and engaging them in chronic care management programs. And forget about value-based care for a minute, right? So, but the point there being is, I need a different economic program to support healthcare, because at the end of the day, we can't say, because it almost should be an illegal term, about not getting, what's the word that you use, authorization to do something. The
And
person
value
is
based care, like you mentioned, who does that benefit? Don't benefit me as a patient, doesn't benefit that doctor that we're crying we don't have enough of, because he doesn't want to, a person doesn't want to be a doctor because of the debt. I'm 55 years old before I can pay all this off, because now, you've lowered what I thought would be my, annual compensation. So why do I even want to do this?
Yeah, so actually, that's one of the reasons why, as you know, because we've talked a lot previous to these discussions. Genie MD as an example, we talk about continuous care, right? As being the interim between episodic care and value based care. Because with continuous care, I can extend care into the home, I can do telehealth, I can do remote patient monitoring, I can do remote therapeutic monitoring, I can do chronic care management, all new revenue streams for doctors. And I don't have to take on one stitch of risk, right? So it's a matter of the embrace of these programs. But the other point there is that the person actually has to have insurance that's going to support those new models, right? Medicare supports it, but does Aetna, does Cigna, does every other healthcare insurance out there support it? Typically, that's where some of the challenges come into play. So, to your point earlier, what health care insurance do you have, and that's going to dictate, what type of quality care you get, and why should one person have a different quality of care than the other just because of, past history of where we come from.
We're so focused time on metrics in healthcare and healthcare systems, average length of stay, whether you're healed or not. You know, you look at what's our census. We look at the continuum of care. Well, you need to go to the next level in the continuum. I wouldn't have to go anywhere. I wouldn't have to talk about value based care. I wouldn't have to do any of that if there was a program for preventive care, for access. Okay, you don't want to leave your house, we gonna come to you, just like we did to bring you the vaccine. Where have we had that? Remember the old days, the doctor had the little bag, you could call him
Dr.
up.
Wilby.
At least he got to see you. That went away. Why do we even talk about average length of stay? If I'm not well, why do I got to be out in 3 to 4 days? We
Yeah.
went from okay, where you could have your baby, you get the fuzzy slippers, a robe, you stay for a couple days. Now 12 hours out.
Out.
Next,
Exactly.
and we're moving so fast, we don't even slow down to teach, to educate. We may say preventive words and phrases, but there's no action behind them. And then when you come in and we find out that, oh, wow, you're at stage 4, stage 3. If you would have came to us 6 months earlier for this and that, we probably could have. You know, that is one of those things that people often hear. I mean, this conversation around healthcare, around access to care, care transformation, around social determinants and healthcare disparities has no end to it. But it would be nice to say, okay, teenage pregnancy, infant mortality rates. You go to the neonatal intensive care, and you see these babies that's the size a little bigger than your hand, because no prenatal care. Mom didn't do XYZ. Well, heck, she's 14. I mean, you hear those stories every day. So there's just so many different aspects of healthcare. But if you're able to start with just one diagnosis, one disease state, one population, one community, one zip code, because whatever your religious beliefs, I always believe that whenever you get where you're going, between birth, the beginning, and death, the ending, and that question is asked. So all that time I gave you down there, what did you do to make a difference? What's the answer going to be? I
Yeah.
made a lot of money. I had a lot of expensive things. I didn't help nobody. Okay. So I mean, it has to reside in a person's heart, and they have to have empathy like you do for others. If you don't have that, and you just have that mean spirit, if you have a board at a hospital that it's all about infection, C. diff, central line infections, all of those things, but nothing in your dashboard that says, what have we done in the community? Besides, we went and worked one day at a food pantry. and stuff some boxes. That was our community event for the year. Where's the healthcare disparities, the social determinants? Where are those listed? That's what
Yeah.
begins to make a difference.
Yeah. Michael, a great conversation, very educational, and I will join you hip to hip going to Washington if you'd like and advocating, as I'm sure you already do. But there definitely needs to be a change, and maybe the folks that have been sitting at the table all this time are just the wrong folks to think about what truly needs to change if we're really going to change our communities and lift everybody up to be one. So with that, I want to thank you for your time, your insights, and I look forward to working with you in the future.
Thank you. Thank you for having me, Tom.
I want to thank the show sponsors, HP. HP Engage Long Lifecycle Products provides the stability, safety, and security you need, plus flexibility and performance designed for today and tomorrow. As well, Genie MD, providing a modular, scalable, and customizable virtual care platform and clinical services to help providers extend care into the home, increasing access and quality while driving new revenue opportunities. If you missed part of today's episode, you can tune in at the same time, 11 a.m. or 7 p.m. Eastern, throughout the week, and be sure to check out the program page on healthcarenowradio.com. And remember, connect or follow me on LinkedIn, Twitter at FoleyTom, and follow the show's hashtag, The Virtual Shift. I'm Tom Foley. Until the next shift.